Welcome back to Get Lit, the Dermatology Digest Literature Lessons podcast with Dr. Ted Rosen, a professor of dermatology at Baylor College of Medicine in Houston, Texas, and the editor-in-chief of the Dermatology Digest.
This is Dr. Ted Rosen, editor-in-chief of the Dermatology Digest, and it's time for another edition of Let's Get Lit. Let's talk about current literature. And in this particular edition, I'm actually going to be quoting a lot of things from overseas. There was some very interesting literature generated from outside the United States. Let's start with a presentation in the EADV, European Academy of Dermatology and Venereology conference, where a Chinese group actually presented data on denifanstat. It's a first-in-class inhibitor of fatty acid synthase, which decreases sebum production, which can lead to decreased acne. So at week 12 of taking this particular kind of medication, about a third of patients were clear or almost clear, compared to only 14% of placebo recipients. And this was accompanied by a 60% reduction in total lesion count. So look forward to seeing this drug. May not be in the US immediately, denifanstat, but coming soon. In the February issue of the Journal of Affective Disorders, a large European patient database was queried, and they pointed out that both rosacea and perioral dermatitis, they surveyed hundreds of thousands of patients with this, were subject to significant anxiety and depression, and that the risks for those psychological disorders increased steadily the longer patients had inadequately treated rosacea and perioral dermatitis. In the November meeting of the American College of Allergy, Asthma, and Immunology, there was an interesting presentation based upon data analyzed from the Trinetics Research Network, which is a global network. They pointed out that a history of atopic dermatitis increases the risk of radiation dermatitis during the first 3 years following receipt of radiotherapy. Now, they were just analyzing breast cancer, but I would not be surprised if that's not also true of other cancers that have to receive radiotherapy, either as primary or adjunctive treatment. So if your atopic patient is going to get radiotherapy, I think you should warn them that they may get radiation dermatitis that'll lead to pain, pruritus, and even potentially secondary infection. In the November issue of Dermatology and Therapy, using Japanese databases, adults and pediatric patients with atopic dermatitis were noted to experience, get this, habitual scratching, even in the abscess of itching. About 45% of Japanese adult and pediatric atopic patients noted that they were found to be scratching, oftentimes when it was pointed out by another individual, hey, you're scratching, even though they didn't have itching. So the scratching almost becomes a habit. And of course, that leads to barrier breakdown, which then allows ingress of allergens and infectious organisms and exacerbates the atopic dermatitis. So I think it's, this is a Japanese study, but I think it's important to at least warn your atopic patients to make sure you don't scratch, even if you're not itching. In the September issue of the Journal of European Academy of Dermatology and Venereology, there was a German study, a pretty big study, 630 odd patients with actinic keratoses. And they compared the application twice daily of 5% potassium hydroxide solution for 28 days to the use of placebo twice daily for 28 days and diclofenac twice daily for 60 days. And guess what did the best in terms of clear or almost clear of actinic keratoses? KOH, 5% potassium hydroxide. 45% of patients treated in this way cleared their AKs compared to just low 20 percentile with placebo and diclofenac. Interesting. I like simple, safe, and cheap. So you'd have to give the patients the potassium hydroxide diluted down to 5% if you routinely use 10, 15, or 20% in your office. And you can get little containers to give them too. There was a global study involving 524 melanoma patients published in the December issue of Nature Communications. Very interesting. These investigators said that certain dermatoscopic features of a melanoma predicted the risk of metastatic disease just as well as the things we rely most on, like tumor thickness. So just your initial dermatoscopic evaluation of a melanoma. What predicted metastases? The presence of the blue-white veil and erosion. And by contrast, heavy pigmentation covering more than 75% of the lesion was associated with a reduced risk, ultimately, of metastatic disease. So your dermatoscope may not only help diagnose melanoma, but it may help select patients who are at highest risk of metastases. So we have multiple ways to evaluate the melanoma patient, including genomic analysis and so forth. But even your dermatoscope might help. There was a large-scale Danish study, over 1 million patients, published in the December issue of the Archives of Dermatology Research. And they found, and I think this is really important, that early onset non-melanoma skin cancer, how did they define that? Basal cell or squamous cell of the skin occurring before age 40 is associated with an increased risk of other non-cutaneous malignancies before the age of 50. How about that? This is a 3-fold increased risk in men and a 2-fold increased risk in women. So if you have a non-melanoma skin cancer in a very young patient, I think it's fair that you warn them about at least a statistical increased risk of internal visceral cancers. And, that might mean that they should have enhanced cancer surveillance or possibly genetic counseling. In the February 2026 issue of JAMA Dermatology, there was a nice study based on veteran population. 1,300 veterans compared to 5,000 controls and 5,000 controls with melanoma in a non-acral location. And it turns out that exposure to Agent Orange during the Vietnam conflict is associated with a significantly increased risk of acral melanoma, regardless of the ethnicity of the patient. Now, Vietnam vets are getting older and dying off, so this is going to become increasingly less important. But it turns that if you have a veteran who says they were exposed to Agent Orange, look at their feet. They may have acral melanoma. At the European Society of Medical Oncology meeting in 2025, there was a nice presentation on data from a trial which showed that adjuvant pembrolizumab improves relapse-free survival and prolonged distant metastasis-free survival in patients with Merkel cell carcinoma that has been resected. That's adjuvant. That's after surgery, pembrolizumab. So I think the way we treat Merkel cell is definitely undergoing some modifications, and this may ultimately be standard of care. There was a really worrisome article. I mean, we think about topical ivermectin as being relatively safe, and that can be used for head lice, for example. There was a cautionary tale in the September issue of the Journal of Internal Medicine Research, where an individual got veterinary ivermectin solution applied once a day under occlusion, so enhancing penetration, for a month, just a month. That led to gastrointestinal distress, cerebral edema, ultimately respiratory and renal dysfunction, and death. So ivermectin, generally considered, used properly, a relatively safe drug, but even topically, when overused, can be associated with significant problems. I thought you should be aware that there's a new device. It's called Flow, Flow, and it's a home-based cranial electrotherapy stimulator. I don't want us to be prescribing it, but since so many cutaneous maladies are associated with depression, hidradenitis, atopic derm, psoriasis, this is kind of an easy way to treat mild to moderate, even severe, in some cases, depression with a home-based electrical stimulator called Flow. I'd just like you to be aware of this drug. It's not available yet, but you may see it. Vixarelimab. It's a first-in-class inhibitor of oncostatin M receptor beta. What does that mean? It doubly inhibits both IL-31 and oncostatin M signaling. We don't exactly know why that's important, but apparently it is, because in a double-blind randomized phase 2b, multi-center, multinational clinical trial, vixarelimab was very effective treating prurigo nodularis. So maybe we'll have even another drug to treat prurigo nodularis. There was a systematic review of treatment modalities for pearly penile papules published in the December Journal of Clinical and Aesthetic Dermatology. They pointed out that laser ablation using either a CO2 or an erbium YAG 2940 nanometer laser worked the best. Electrocoagulation could be used for really tiny pearly penile papules. And the most important thing I think they pointed out was that liquid nitrogen therapy was not uniformly successful. In fact, quite often was not successful. Another cautionary paper published in the December issue of JAMA Dermatology, 166 patients attending a Harvard-related dermatology clinic were surveyed, and an amazing number did not know the meaning of common dermatologic terms. For example, they didn't understand clear margins. They didn't understand the phrase pathology results. Only 1 in 5 vaguely understood what a dysplastic nevus was, and only 13.5% could correctly define the word actinic. 15% thought malignant melanoma was benign. I think you need to just remember that people not trained in medical specialties may not understand what you're telling them. Even if you do it slowly and clearly, you may need to explain terms. Using a structured phone interview, 29 survivors of Stevens-Johnson syndrome and toxic epidermal necrolysis were surveyed. This was published in the November issue of JAMA Dermatology. You think you get someone passed, healed from Stevens-Johnson or toxic epidermal necrolysis, you think your job's over. Well, not really, because they're suffering from anxiety, depression, negative flashbacks, ongoing skin problems, and visual impairment. So you need to follow up with those patients to make sure they're doing well, and they may need to see a mental health professional or an ophthalmologist. In the January issue of Journal of Drugs and Dermatology, there was a nice review based upon analyzing data from the FDA Adverse Event Reporting System. And this data was looking at cutaneous side effects from the GLP-1 receptor agonists, which are being widely used now, of course, for diabetes and weight control. And it's been strongly suggested they may be part of our armamentarium for treating things like hidradenitis and psoriasis. But keep in mind, they do have side effects, and about 6% are cutaneous, including injection site reactions, a generalized nonspecific maculopapular eruption, generalized urticaria, widespread itching, or allodynia, which is widespread skin pain, alopecia, and hyperhidrosis. These cutaneous side effects from GLP-1 drugs were most common with semaglutide and least common with dulaglutide. So there is a stratification here. Don't forget, there are other side effects from these agents, including things we need to really worry about, like pancreatitis. In the January issue of BMC Endocrinological Disorders, there was an interesting Chinese study looking at diabetics who itch. And it turns out this is strongly associated with lower extremity xerosis, and itchy diabetics, even with nothing to see on their skin, have an elevated serologic level of IL-4, which suggests perhaps that our agents which block IL-4 might help that specific kind of itching in diabetics. In the January issue of Frontiers in Medicine, there was a systematic review including 8 randomized control studies involving 564 patients that demonstrated, wait for it, that acupuncture has a better clinical efficacy rate than antihistamines, even at optimized doses for chronic spontaneous urticaria, and that acupuncture can reduce serum IgE levels. Okay, I don't know, but lots of complementary and alternative medication interventions have been used outside the United States very extensively for many years, if not hundreds upon hundreds of years. So just keep it in mind. If you have someone, you've tried all the new drugs for CSU, you find an expert in acupuncture, maybe they should try it. Generally considered pretty safe procedure. In fact, your speaker here had intractable low back pain. Nothing worked. They said I needed a spinal fusion, which I really didn't want. I was convinced to try acupuncture after 2 sessions about 30 years ago. My back pain disappeared and never came back. So just keep it in mind. There was a small Iranian study, 22 patients only, published in the February issue of the Journal of Cosmetic Dermatology. But I think it was important. They noted that the combination of cryotherapy and intralesional corticosteroid injections was not better than injection therapy alone. I know some of you may well use cryotherapy as an adjunctive therapy for alopecia areata, but if you combine it with intralesional injections, the intralesional injections do just as well, all by themselves. So why put the patient through the cryotherapy? That's the conclusion of this very small study. There's been a lot of published data recently on hidradenitis suppurativa. Some of it's very interesting. For example, in a summertime issue of JAMA Dermatology, there was a large retrospective analysis of HS patients done in the US, in New York, and it pointed out there was a large cardiometabolic risk if you follow HS patients over a 10-year period. In fact, 83.9% of HS patients had at least one cardiometabolic risk factor, such as high blood pressure, hyperlipidemia, diabetes, or the full metabolic syndrome. The degree of cardiometabolic risk runs in parallel to the severity of HS. So if you have a severe HS patient, either you or their primary care provider needs to look at them for these cardiometabolic features. In the November issue of the Journal of Cutaneous Medicine and Surgery, there was an extensive review of surgical outcomes in patients with early stage 2 or 3 hidradenitis. This study looked at 136 publications, which included 5,646 procedures. And I think the one thing that came out of this review was that the worst recurrence and worst complication rates occurred using excision and primary closure. Anything else is better than that. In the September issue of Emerging Infectious Diseases, CDC investigators summarized data to suggest, wait for this one, that Chagas disease caused by Trypanosoma cruzi is actually endemic within the United States, and we just don't look for it. So in states like California, Arizona, Texas, Louisiana, Missouri, and Tennessee, there have been well-reported, well-documented indigenous human cases of Chagas disease. So keep an eye out for it. From a dermatologic standpoint, early disease is characterized by the Romagna sign, swelling of the eyes. People always ask, well, we know that the CDC recommends either ivermectin or permethrin for the treatment of scabies. Is there one that's better? A French study looking at 500 scabies infected individuals who were given either ivermectin, 200 micrograms per kilogram standard dose, or asked to apply permethrin in the standard manner. Both treatments were given on days 0 and 10, so each treatment was used twice. And then at day 28, the assessment showed complete cure in 88.5% of those who received permethrin, compared to only 71.8% of those who received ivermectin. Both adults and children weighing more than 15 kilograms were included in this study. So this data from France suggests, doesn't prove it, suggests permethrin may be superior to ivermectin. In the January 26 issue of the Annals of Internal Medicine, 154 individuals who had had Mpox, the new terminology for monkeypox, a year to a year and a half previously were analyzed. And it turns out that even though this disease usually spontaneously will regress or can be made to regress with therapy, turns out that they still have problems. Dyschromia and scarring at the sites of infection are common. as you might expect. But the other thing is that 13% demonstrated persistent anorectal or urinary functional abnormalities like difficulty defecating, stool or urinary incontinence, and difficulty starting a urine stream. 45% of participants in this study also reported depressive syndromes, and 20% reported negative effects on sexual performance. So just like Stevens-Johnson and TEN, just because they're over the disease doesn't mean that for them, it's over. It's like an Adele song. You need to watch these people and send them appropriately. They might need to see gastroenterology. They might need to see urology, even after their skin lesions have healed. In the January issue of BMC Surgery, there was a nice systematic literature review, 6 studies evaluating the effects of metabolic bariatric surgery on psoriasis. Get this, I'm not advocating it, but it's always nice to have some extreme intervention available when all the standard things don't work. Get this, gastric bypass led to improvement, significant improvement, or complete remission of psoriasis in 80% of those who got gastric bypass. DLQI scores improved and PASI scores decreased. And other therapeutic interventions could be either reduced or discontinued entirely. So this is another way to approach severe psoriasis. And then the last thing I'm going to mention also with psoriasis is in a 32-week multinational study published in the December 2025 issue of the Journal of the European Academy of Dermatology and Venereology, there was a study done on apremilast for moderate to severe genital psoriasis. And it turns out about half the participants who received apremilast, either continuously or after a period of placebo administration, about half achieved and maintained clear or almost clear. So apremilast looks like it may be very good specifically for genital psoriasis. So that's our Get Lit issue. I know it was a little long, but there was a lot of good stuff out there and some good clinical pearls. Nice to have them in your back pocket when you need it. This is Dr. Ted Rosen, Editor-in-Chief of Dermatology Digest, signing off, and I'll see you next time.
Thank you for listening to the Dermatology Digest's Get Lit podcast. For more information on any of the studies referenced, visit thedermatologydigest.com.